Welcome back to The Blend, a podcast brought to you by the Journal of the Dermatology Nurse Practitioners and Physician Assistants and the Dermatology Digest. In this episode, host Dr. Sonal Choudhary, Director of the Integrative Dermatology and Skincare Clinic at the University of Pittsburgh Medical Center, talks to Dr. Peter Leo about his top 5 tools for managing atopic dermatitis.
Welcome back to The Blend. Today, we're continuing our conversation with Dr. Peter Leo, but this time we're shifting into something incredibly practical. Dr. Leo, I love this concept of active dermatologic care, or ADC, and you have these top 5 tools for managing atopic dermatitis that we would love to learn about because it reframes this moisturizers and cleansers as biologically active interventions. And please correct me if I'm not presenting it appropriately for you, but it's just not just this passive skincare, right? So we would love to hear from you how you define ADC, or active dermatologic care, in your own words.
Oh my gosh. Well, thank you. Thank you for the kind introduction, and thank you for having me. And I think you did a beautiful job of introducing this because it's something that we know and we talk about and we think about all the time, but we haven't always given it a name. And it was so fun. I got inspired actually from Dr. Hilary Baldwin, a wonderful dermatologist and really a key opinion leader and thought leader for acne and rosacea in particular. Obviously, she's a great dermatologist in general, but she wrote a paper just in the past couple of years, and she called them acne-ceuticals. And it was the idea that there are some over-the-counter things that are almost like pharmaceuticals that are actively affecting acne. And I thought, my golly, this is a great framing of it. And I thought, could we broaden this concept? Because this is true for me for atopic dermatitis, for rosacea, for psoriasis. And I think calling everything a ceutical also kind of suggests that it is RX. So I just like the idea that it's part of active dermatologic care. It's something we're going to add to whatever our main treatment's going to be. So maybe it is going to be a biologic agent for psoriasis. Maybe it's going to be an oral JAK inhibitor for atopic dermatitis, but we're still going to talk about these fundamental aspects, which you notice are in every single guideline document. And all of our teachers have always spent time teaching us to tell our patients, make sure you emphasize gentle laundry detergent, gentle soap, good cleanser that we're going to use, a good sunscreen that's not going to irritate your skin, all these pieces of the puzzle. And one of the hardest parts for me, well, 2 hard parts. First part is that the science of this area has continued to honestly accelerate and grow arguably just as much as what we're seeing in the RX world, maybe more in some ways. There have been some breakthroughs in this kind of OTC domain, and we don't really have a great forum to talk about it. Some of this stuff will happen in more cosmetic journals or more formulation type journals, and we don't see this in clinical dermatology because I guess we've sort of been trained not to use the brand names, and there's not a really good way to talk about a moisturizer without saying a brand. So we end up saying the same thing over and over. Oh, a gentle bland moisturizer, a gentle cleanser. But on the other side, the second problem is that for our patients, I think we're actually now doing an active disservice by just saying pick a gentle moisturizer or pick a good moisturizer, whatever that may mean, because now when they go to the drugstore, it used to be when I was a kid, there might be 4 or 5 choices and they could figure it out, maybe ask the pharmacist. Now there's 4 or 5 aisles of skincare. So they're like, well, which one should I pick? I mean, are they all the same? And I've heard cynical people say that, oh, it doesn't matter. It really doesn't. I beg to differ. I vehemently beg to differ. I think it does matter. I think it matters a lot. And there's all this data and all these great studies suggesting that if we think a little bit about it, we potentially can do better for our patients. And that's a big deal because for some patients, it could be a literal straw that breaks the camel's back, right? It's not the weight of the straw. It's the weight of the straw in addition to all the other stuff. So maybe there is a patient out there who might have to go on a systemic agent, but if you just enhance their topical non-prescription topicals, you get them better. That active dermatologic care, they say, you know what? I'm okay. I don't need to go on that systemic. And to me, that's a huge win. Everybody wins. It's money winning for the system. We're not spending tens of thousands of dollars on that patient. It's safety winning for the patient. We don't have to put them on additional medications that have risks. Of course, a lot of systemic agents have potential risks. And it's a win for us. We get patients better in a gentle way, which is really what we're trying to do.
That actually summarizes what I was about to bring up. So can we name this eczema ceutical then? Is that a word?
I think that is definitely a possibility. I kept it a little more general with active dermatologic care, but I love that.
You heard it first on this podcast, eczema ceuticals. It doesn't have a good ring to it, but I will go with ADC. A good eczema plan, I think, is everything. I take a lot of time. My residents sometimes roll their eyes at me and they're like, you're talking for so long and so much, but I'm on your team about the education piece is very important and to find the right fit. And there can be some trial and error associated given how many products we have to our disposal now, especially in the over-the-counter products. But I think one of the non-negotiables with atopic dermatitis, eczema care for me is moisturizer. And there's so many. How do we pick? How do we decide? So much data, sometimes lack of data. So I always access it in this way that patients, you have to use a moisturizer that's non-negotiable. And then all the other things that I'm about to tell you might help with that inflammatory component. And I don't think we know very well which one came first. There's a chicken egg situation. Does in some people, the dryness and the barrier bring up the inflammation, or is it the other way around? So we have to manage both those components. So I'm on your team with that. So what does your good eczema action plan include? Does it differentiate for mild, moderate, and severe patients? And again, like you mentioned, we want to empower our patients. We don't want to overwhelm them. So I know for a fact that you write every single plan down for your patients. I have seen it. I have learned it from you. But also, do you actually use a digital version? Do you actually write it on paper? So what does this good plan look like for you?
For me, it really does look like something that I'll print out for them. So I have a template that I'm updating and I personalize for each patient and I print it for them if they're in clinic. If I'm doing tele, then I can just send them the file. But what I like is to print it out so they have actually something in their hands. And then I'll tell them, use your cell phone, please take a photograph of it too, just in case you lose it. Now you have your own digital copy, which is really nice.
Mhm.
And I think it should include literally everything we're going to ask them to do. So for example, it's going to have two different plans, a flare up or a rescue type plan for when they're having some trouble, and then a daily maintenance plan that they can do when they're better. I really like to differentiate these two states. And some people say, boy, doesn't that confuse them? And I say, it could. There are some patients you have to maybe break it down differently, but most patients really like this. And I say, when you're having some trouble, this is your rescue plan. You're going to do this. And I list them in order too. So I'll say, in the morning, I want you to do number one, apply your steroid to your affected areas. Number two, I want you to moisturize liberally. In the evening, you're going to do your gentle bathing. Then you're going to put your steroid ointment. Then you're going to put your moisturizer liberally. And then you're going to do your wet wrap if you need it. You're going to do that for a period of time. So I'll build that in there. Maybe I'll say 3 to 5 days. Maybe I'll say 1 to 2 weeks, depending on the patient, their age, their severity, and I'll customize that. And then I'll say, once you're better though, then you go to that maintenance plan. And there, maybe we're going to have, instead of a steroid, a non-steroidal agent in its place. Maybe it'll be something that's once daily, like tapinarof or roflumilast, or maybe it'll be something twice daily, like ruxolitinib or tacrolimus or pimecrolimus. So it's great. We have all these options. Or if it's a real mild patient, and then maybe when they're better, there is no medicine at all. They're non-pharma. It's just their great moisturizer and then their cleanser. And then the bottom half will list the very specific products. And I like to put a link. And I'm not trying to give Amazon any business, and I certainly don't get any money from it. I had a patient ask me once, like, is this like one of these like affiliate links? I'm like, oh golly, no. I'm like, you notice how short it is? You can just get it yourself. I'm like, but I just like you to see the exact product, because something that's happened to me and probably happened to all of us, whether or not we knew it, is you'll say, get this. Here's a couple of good examples. You name some good name brands, and they actually get one that's made with urea for psoriasis or for like calloused feet or something that has like fragrance or beads. Or it's like, oh my goodness, because a lot of the brands have dozens of SKUs, right? All these different products within a brand. So I really try to be very, very specific. I don't give them one option. I give them a few, but I say, these are a couple of great ones. And if I have a picky patient, then I like to bring in some of those products into the room and say, let's try them together right now. Tell me which one you like. And it is so much fun when they try one, they go, oh, I don't like this one. Oh, no, I can't use that one. Then they find the one that they like and they say, I like this one. And it's a little kid. It's so funny. Their face lights up and I'm like, perfect. This is your new moisturizer. Here's a few more samples. You know exactly which one to use because now I know you like it. It's so powerful.
It's so important too. Like if they're going to use it, that's the only time it's going to work. I had a patient literally yesterday. It was such a funny conversation because there's mild eczema, and I was like, "Well, are you using a moisturizer?" And her answer was, I have bought it. And I'm like, okay, well, the next step would be to apply it so we can make sure it works for you. But sometimes because of the texture or how it sits against their skin, I have had very interesting conversations around that. Samples really come in handy in those situations. So number 2 will be the vitamin D, which made to the list here. Now, it's not a topical, but as we discussed in the previous episode, a lot about vitamin D. So we do understand why it's one of of your favorites. Do you have a threshold at which you would use it to treat? It is on your list of ADC. Do you check the levels routinely? Do you ever have like a, do you think of it as like a low risk or a high reward component in this setting?
Absolutely. I think that it's one of those things that I used to check levels. And since then, I realized that it's not worth it. Most of my patients, honest to God, the vast majority are quite low. Now, they're still low normal. They're often above that threshold, which can be as low as like 30 or something, but they might be like 37 or 40. So they're on the low end of normal. And I kind of stopped checking because I realized, well, nobody's necessarily in danger, truly deficient in vitamin D, but a lot of people are on the low end. And I really think that when we see these correlative studies showing that the lower your D, the more severe your eczema is, it makes sense to bolster our D, especially given one of the huge problems in modern life. And I really do. I'm maybe a little iconoclastic here in terms of some of our colleagues. Some dermatologists, our colleagues are very, very insistent of avoiding sun always, right? I mean, this is a real thing. And many people, they'll probably put on their gloves and they'll have their special sunglasses and hats and sunscreen every 5 minutes. I think that's great from a skin cancer standpoint. I cannot argue with that. I think that is very wise. And from an aging standpoint, for sure, if you protect your skin from UV radiation, you are going to look great, right? Because that is a huge cause of aging. On the other hand, again, maybe it's because I'm more holistic. I'm more granola, crunchy, thinking about it from the whole person. I do wonder if maybe that extreme is a little bit too much for most people, and that some sunshine is actually probably pretty good for us. Yes, at a cost of skin aging, at a cost of potential skin cancer. And I absolutely don't recommend people sunbathing or burning or getting bronze. Like, no. There's again, middle path. Middle path, though, might mean it's okay to get some sun in the early morning or the late afternoon, and for little kids to get some, especially depending on their skin type. Obviously, if somebody is redheaded and freckles and burns in just a few minutes, well, golly, that's not someone who I want out there. But somebody with medium skin tone, they, I think, are able to and probably should get a little bit of sun and not be slathering on sunscreen all of the time necessarily. But I'm open to debate on that. I could be convinced otherwise. But that being said, no matter how you slice it, even if we weren't crazy with sunscreen, modern life keeps us out of the sun. We're indoors for so much time. And if you live in climates like we do, kind of in the Midwest and the parts of the country where we don't get a ton of sun and we have hard winters for many months out of the year, we barely go outside. And when we do, we're all bundled up and we're running to and from our car. So because of all this, I really think that vitamin D supplementation is a great idea for everybody. I think the risks are extremely low. Can you get hypervitaminosis D? Yes, you can. Have I seen it? I actually have, but it is really, really rare. It's once in a blue moon. And I think so long as we're not doing mega dosing, I do daily dosing. I'm doing, again, over-the-counter preparations. They're not terribly expensive. I truly think, and again, I could be open to be proven wrong, and I'm always trying to read more and get more data and evidence, but I really think we're doing far more help than harm. And there are a group of patients who really turn around. And I actually, last piece on this, but I don't want to beat it too long, but Rob Sidbury, rest his soul, he was a wonderful pediatric dermatologist. One of the studies he did, which really broke this whole area open, was looking at children who had winter worsening of their eczema. And he gave them vitamin D versus a placebo. And the group that got the vitamin D, even though it was only something like 12 patients, it was so dramatic that it was published in the British Journal of Dermatology. It made such a big difference. So I really believe there are kind of super responders to vitamin D sup. And that's what I tell my patients. I don't know who's going to respond and who's not. It's pretty darn safe. It's pretty darn inexpensive, but I'd like you to try it. And I can tell you, so many patients come back and say, wow, I think this is helping.
That's awesome. Because, this paper that you're talking about, was this the one done in Boston?
Yes, exactly.
Yes. Okay, you good. Yeah, it had 11 patients that all responded. It was phenomenal. D3 plus K2, any comments on that? Or do you just do regular D3?
Typically, I just do regular D3. The K2 is probably important in the big picture for overall bone health, but the ones I've usually recommended are just D3. I also really like there to be, the one I pick for adults actually has some omega fats in there as well. So I think that helps. First of all, the omegas can be nice for atopic derm and dry skin, but also for absorption too. So that's the one I pick. But I definitely understand why many people like a D plus K3.
Yeah, I do tell people when they're asking me specifically, hey, which one should I get? I say, well, since you're asking me, get the D3 plus K2, and they're easily available OTC now. So a comment on that, getting some sun while preventing skin cancer. I have found that telling people that you can still go out, you should go out because we need our circadian rhythm to function appropriately for everything. Even with eczema, I feel like, there's so much data suggesting that if there is an upsurge of melatonin at the right time in the evening, that corresponds with the right upsurge and downsurge accordingly of cortisol. And that can have such an important role in atopic dermatitis itself, but also like just maintaining that circadian rhythm for general health and well-being. So go out in the morning when the sun is rising, and also in the evening, so you can see the sky and you can have that regulation. But midday, when it's what we refer to as the circadian block, when the sun is right above, that has a little less impact for goodness for us. So limit that. Don't bake yourself in the sun, just like you mentioned. So that's kind of what I explained. So it doesn't feel like I'm taking away joy from them, but leaving some ideas for them to use. Probiotics, we already kind of talked a lot about probiotics, so I will not, ask too many things around that. But one question that I feel like we should bring up is that something that, why does that fit so well in your ADC model? You had mentioned that, that is something you do give to most of your patients, almost all of your patients. Do you switch probiotics after a certain time, and what factors do you take into account to do that?
Usually, I use the same combination strain of probiotics for pretty much all the patients. And then, unless they have an issue, if there's some issue that comes up, or if they want to try, sometimes the family will say, "We heard about this one," or "My cousin tried this one. Can we try it?" And my general answer is sure, because we know the level of evidence is not that great. So I'm up for people trying things, and I'm sort of patiently waiting for the state of the art to continue to advance so that one day, and I'll also pair it to the other question that comes up a lot around this is, should we do some kind of microbiome testing, like gut testing, to help shape us? And here's my answer. I wish, I want to, but I look at these tests and I don't really understand if they are reliable enough to make a clinical decision on. And I honestly don't really know what to do with a lot of the data I get. There are certainly clinicians who are smarter than me and better than me who can interpret these things, I think, but I've tried to learn, and I just feel like, in good faith, I don't feel like I can make evidence-based decisions off of this, but I believe in my heart of hearts that this is the path to precision or personalized medicine, and that hopefully in our lifetimes, we're going to get to the point where you say, yes, we got to check your microbiome. That's going to help us know which ones to give you. I mean, how else would you do it? I mean, it makes sense. I just don't think we're quite there yet, but hopefully soon.
Very early stages, agreed. So what makes a moisturizer great? Because that's our tool number 4. I know it sounds pretty simple, just a moisturizer, but we know it's not. So do you prefer ceramides? Do you go more for like ointment versus cream versus lotion, or it depends on the weather, season, skin? Do you ever prescribe a barrier repair product like a prescription moisturizer? And do you have a specific on how often should one use it? So how do you speak about your moisturizers and pick one for your patient?
So first thing, I love my dad always has this phrase, every pot has a lid. And I think that is true. Everybody has something that will fit them or suit them well. And it's true for moisturizers too. I don't think one size fits all. And that's important. And of course, cosmetic acceptability is really key for this, especially for kids and teenagers. If they hate the way it feels, and anybody really, if it feels uncomfortable on your skin. I have some patients who you put a heavy occlusive moisturizer on, they say, "Oh, I hate it. I feel like it's hot and itchy and uncomfortable." That's not going to work. Other patients, if you put something too light on, they say, "Oh, it burns and feels bad. I need something a little bit heavier." So I'm looking at a range of moisturizers. First of all, I also say that I really dislike when people use the term emollient synonymously with moisturizer, because to me, a moisturizer has different components. And ideally, a great moisturizer has a balance of these components and even more. It has an occlusive aspect that helps seal the barrier, lock things in. It has humectants that pull water and hold it in place. And it has emollients, which tend to be oily substances that soften and smooth the skin. So if you just say an emollient, it's kind of like, well, that's sort of part of the puzzle, but we're talking about the whole piece. And I want those things. And then you're right, they can have more. They can be moisturizers plus, they can have ceramides, they can have other botanicals in there, they can have different types of anti-inflammatory pieces or pieces that can affect the microbiome. So all these different pieces of the puzzle, and it's been so cool to see the state of the art moisturizers and how they keep getting better and better and better, and to watch the development of this field. It's just remarkable. But my favorite thing to do is bring in a handful of samples and talk to the patient about what they've been on, what they like, what textures they like, what things maybe they had luck with or didn't. And then that can really guide me to give them some to try. Another great resource, because I know we don't have that much time today, but I want our listeners to be able to find some resources. The National Eczema Association has this incredible database. It's called the Seal of Acceptance Program. And if you go to the National Eczema website, you can find it very prominently there. And there are dozens, if not hundreds of moisturizers that have sort of passed the basics for what we want our patients with eczema to use. It is a great place to start. It doesn't have the answer for you, but I think it has a whole bunch of potential answers for patients. So for when people say to me, well, can you give me 5 good ones? It's like, well, check there. And of course, I'm always happy offline to give people the ones that I tend to default to.
Tool number 5, great cleanser. What is a great cleanser and what do you look for your patients in a great cleanser? I'll tell you, my number one thing is I tell them to go with something that their skin likes on a repeated basis. And sometimes I tell them to switch between two. So let's hear from you. What is your approach towards cleansers?
I like that a lot. And I think we've seen it go from the old-fashioned soaps, true soaps, which are saponified fats, which are incredibly alkaline and damaging to the skin. We knew not to use those. So we heard people say, do not bathe much at all, because that was harsh. And then we had our synthetic detergents, our Syndets, which really revolutionized this. But now I think we even have cleansers that do more. So my favorite cleansers are ones that have fats or oils in them that, to me, can actually leave the skin more moisturized than before you use the cleanser. So not only are they non-stripping, right? They're not just neutral. They're actually doing a positive change for the skin. And some of these have things like castor oil in them or soybean oil in them that actually can help moisturize the skin and leave the skin soft and supple. And I know it because I try them. I physically tried them myself. And it's just incredible to see how your skin feels after using some of these very sophisticated cleansers.
Thank you. Thank you for that, Dr. Leo. We will definitely have you back to talk more about the science of some moisturizers, because we know they're not all the same, maybe in a future episode. And we really thank you for providing this amazing framework, which is so practical, so empowering to the patients and to the providers for their patients. And we can help build a more, instead of just being passive and maintaining things in a, unthoughtful way, this provides such an active, biologically thoughtful care that we will all be able to use it from here on. Thank you so much for joining us.
Thank you again for having me.
We hope you learned a lot from this episode of The Blend. Thank you for listening, and see you next time.